listening to The Doctor's Corner with Dr. Kline and Janelle Elgoway.
Good evening and welcome to The Doctor's Corner on Kline. I'm your host, Janelle Elgoway, and we have Dr. Kline here. How are you, Dr. Kline? How you doing, Dr. Kline? Hello? Okay.
There we go.
There we go.
I hit the cough button again.
It's okay.
I'm just dandy.
Good. Tonight, if you have questions for Dr. Kline, please call in at 415-915-2291. You can also chat live with our audience on YouTube channel Conspiracies Against Wellness livestream. So tonight, we are going to focus on pain management and pain management clinics. Dr. Kline, what exactly is a pain clinic?
I always kind of start at the beginning with the history of things.
Okay.
Anesthesiologists are people who administer local anesthetics, such things as saddle blocks for pregnancy, which are now called epidurals. Sometimes if people had heart disease, they would get a regional block. In other words, you can make a person's leg numb by using Novocaine, like the dentist uses. So these were the original people that knew how to do this. Then doctors, physical medicine and rehabilitation learned to do injections or blocks or phenol blocks for people with spasticity. They would find a nerve that goes to the muscle, and then they would put some phenol in it and would stop the spasticity of the muscles. So those two groups of people were skilled in injections of anesthetics.
So that's why anesthesiologists are pain management?
Correct.
Okay, gotcha.
And PM&R doctors, that's physical medicine and rehabilitation. Those two doctors are the most common that you'll see in a pain clinic. So in Seattle, they started the first pain clinic back in the mid-'70s with some anesthesiologists. And the anesthesiologists have been promoting themselves as pain experts, but they focus on injections.
Okay. Do they actually, so they don't go to school for pain management or how
No.
is that? Okay.
Pain management has always just been something you develop yourself. There's been no official pain management fellowships, etc., until recently. So until maybe 10 years ago, everybody just kind of hung out their shingle. When I was in Boston, we had an anesthesiologist who I would refer patients to occasionally because he knew how to block pain. Somebody has a metastatic cancer in their chest wall, he knows how to put in some anesthetics to block it, and then you can use long-term anesthetics as well. So that's how it kind of got started. And then the clinics got started officially at the University of Washington in Seattle, and they were opened as multi-specialty clinics. Multi-specialty always sounds good. You know, a lot of different people are going to help out with your pain. The dietitian, the psychiatrist, the physical therapist. So everybody got together in these kind of big clinics with all these other people helping. The problem is with chronic pain, people that we see and people that follow us, is most of these other things don't work. So you go to the pain clinic and then you want some pain medicines. Oops. The anesthesiologist is really not trained in pain medicines.
And when you say things, most things don't work, what are you referring to?
Well, for example, we did some Twitter polls, kind of getting some information about this because I always had wondered. Mm-hmm. Let's see. Physical therapy made things worse half the time. Mm-hmm. Helped some, 20%, did not help another third. So the majority of people didn't help them at all. Spinal stimulators, which are commonly prescribed at pain clinics, only worked 14% of the time. Injections didn't really look too good on the Twitter poll we did. They were given to reduce pain, and 12% said they had some decrease in their pain meds for 2 months. 4% said they were able to stop their pain medicines. 61% said they needed more pain medicine.
Wow. Why do you think that is?
I don't know. I can't really speculate on what's going on inside pain clinics. But we did another survey, and we asked, how many people felt like they were getting good care at the clinic. And 25% said they were getting great care. 50% said they were getting worse care. Now, this is compared to their previous doctor. And 25% said they weren't really sure. So based on these polls, we start to wonder what's happening in pain clinics. And I can only say what we found on our polls and what people are telling us about the pain clinics.
Okay.
So a disturbing, at least to me, and a surprise when we did the poll, was we found out that about a third of patients were getting pain medicines and doing fine. Mm-hmm. A third of the clinics weren't even using pain medicines, only injections and spinal stimulators and physical therapy.
Now, is that more recent because of the opioid epidemic or crisis, or?
I think so. The polls that we have were done over the past year. Mm-hmm. Growing up as a young doctor, we didn't have pain clinics. We didn't have pain management clinics.
When did that start? What made that popular? Because of all this, or?
Well, I think it really accelerated over the past couple of years since the CDC guidelines came out, kind of scaring everybody from giving out pain medicines. So the pain clinics, with their rather draconian contracts, were done basically to protect the clinic. That maybe the DEA or a board or something could look at these contracts and say, well, this definitely would preclude anybody coming to the clinic who's a drug seeker or addict. Imagine that,
Yeah.
How horrible that would be to have a drug seeker or a doctor shopper. These people are considered now in our culture to be like El Chapo, to be considered like they're some sort of horrible person because they're seeking drugs. People seek drugs for two reasons. One, they're undertreated, which is actually the most popular reason people seek drugs. And the other is because they have addiction disease. And maybe it's getting time we decide whether people have addiction disease or they have criminal personalities. Mm-hmm. You can't have them both. You need to make up your mind. So everybody says, oh, it's a disease, but then they kind of slip over to the criminal thing. Let's catch these doctor shoppers.
Right. So
the pain clinics have these big contracts in order to protect themselves.
Okay. We have a call. Caller from area code 316. What's your name?
Stephen.
Hi, Stephen. What's your question?
Well, in my hometown, there are 2 pain clinics. There are several that are medicinal pain clinics that prescribe opioid medications that will work, because patients know what they are taking and have had success with those. The 2 pain clinics that are operated by interventional pain management doctors are by anesthesiologists like Dr. Kline has described. One has a policy that they do not prescribe any opioid medications. And what they do is you, as a patient, come in and get screened and tell them where your pain is located. Then they do a diagnostic test by using needles to interrogate the region or poke around on you until they can cause the pain to be worse, after which they administer a block. This is very painful. They will not prescribe a opioid medication during the interim because they want to see if their block is going to take effect in the next several days. The other pain clinic has an anesthesiologist as its head and has 10 mid-levels, and his policy is for $2,500, he must do 3 different nerve blocks on any patient before any of his mid-levels will prescribe any additional pharmacological medications, opioids, even if those have worked in the past. But that's his policy, is I get to do 3 shots on you before you get any medications. I'd like to know Dr. Kline's or yours, Janelle, thoughts on this, because this seems to be a little bit counterintuitive to why would a patient who has taken a medication before and they know that it works want to put themselves through painful procedures just so they can get peck on the bar and a piece of candy will drop off for the rat.
Gee whiz. That kind of sounds like the old neighborhood I lived in. They came by and said, you give us $10 a month and your bicycle won't be stolen.
That's exactly right.
You know, when somebody says you can have something you need or want to keep if you pay us money, I think that's something that needs to be investigated by the district attorney.
It absolutely should be. Because
that's just unimaginable that people are doing that. But that's what our poll showed too.
Right, it's a bait and switch.
It's bait and switch. Yeah, you
and
do.
In fact, this one pain clinic, the second one I mentioned that has the 10 mid-levels, he has been looked at as having a premier pain clinic because he does all the interventional blocks, but his mid-levels will then prescribe opioids. And many of those opioids end up on the street, apparently. And also, he's had 14 deaths. I don't think those are from the blocks. But they won't go after him because he's an anesthesiologist, where they'll go after primary care doctors for prescribing useful medications that are known to work, that have been around for 6,000 years.
Yeah, that's to me, as a practicing primary care physician, is pretty awful. And, you know, unless they can explain themselves as to why they would do this. Now, my experience early on in the 70s with my anesthesiologist, this would be a temporary procedure and only in certain areas. You know, rarely ever did spinal, or rather back injections. This was always local. You know, somebody's had an amputation and they have terrible pain in their arm, or somebody's got a metastatic cancer lesion. But it was very, very selective. It does seem in talking to people that there's a $1,000 injection for every problem. Mm-hmm. These are very expensive. 1,000 is sort of the minimum I've heard. I've heard of people getting 20 and 30 injections. If you don't have anything else that works, people are desperate and they'll go get the injections or they'll go to physical therapy. I can't tell you how many people have told me that they're much worse after physical therapy because people have these disastrous bad backs and, you know, with bones out of line, and they're going to the physical therapist. And a lot of physical therapists are pretty honest. And they say, look, you know, I'll give you some strengthening exercise you can do at home, but you don't need to be here. A lot of times the pain clinics also, you know, have their own physical therapist. I personally think, from what I've been hearing on my Twitter feed, which is now 19,000 people, that the pain clinics need to be investigated. We talked about pill mills before, and really the only bad pill mills were in Florida. And they were pretty awful, but they were missed for several years. You know, they just kept on cranking out the medicines into rural areas. And finally now they're doing investigation of pain, or rather of people prescribing pain, but these pain clinic or pain management people really need some standards, and they need to be investigated because it's new. It would be kind of like freestanding surgical clinics, where a bunch of doctors get together and say, we're going to have a little operating room in the back of our office. Those needed and now have some, oversight and restrictions. But I read that somebody brought me a pain management contract. It's just awful. Mm-hmm. But if people are supposed to bring in their pain pills for counting, how humiliating is that?
Well, and they could do it they could call you even before your appointment and say, I'd like you to bring in your medication. I've heard even. It's getting really bad. It's ridiculous.
The caller from Seattle, I heard that there was a fairly large system of pain clinics that were suddenly shut down by I think it was the Board of Registration in Medicine. Do you know if those have come back? Or my understanding, those were standard, we give medicine pain clinics. Are they still out of commission, or caller, are you still there?
Stephen, are you there?
I'm still here.
Go ahead.
Yes, I am. I don't know if they are still in business. I had two other questions, though.
Mm-hmm.
Why wouldn't we use the term injection mills?
Well,
if they use a injection technique that may work 50% of the time and is very costly, but they had just crank those people through like crazy. And then the other thing I would like you to address, Dr. Kline, is there is no FDA approval
mm-hmm.
for epidural steroid injections. Yet that's what these interventional anesthesiologists tend to use quite significantly on back injuries, particularly lumbar epidurals. And
well,
as I know, there's no FDA approval.
That's what I've heard too.
That's another thing that should be included in the investigation. The other thing is, with the low return from the injections, that is a lot of pain, and then they wear off.
Mm-hmm.
So you got to keep coming back. It's kind of the gift that never quits giving.
Also, you're not supposed to have more than 3 in one area. Is this correct? Or else your soft cell tissue starts breaking down?
Good point.
Mm-hmm.
Steroids,
well, you can get scar tissue.
Destructive. Go ahead.
Right. You're limited to 1 injection with steroids every 3 months. And now has been poorly diagnosed or underdiagnosed, grossly underdiagnosed, is the side effect of adhesive arachnoiditis,
mm-hmm.
which comes directly from manipulating the epidural space.
Yes, we are definitely seeing that, and there seems to be a correlation in the people we talk to with adhesive arachnoiditis, which is an awful, awful, painful, long-term disease.
Dr. Kline,
and also after surgery.
Sorry. Are steroid shots considered blocks?
No.
Okay.
Blocks have...
typically...
go ahead. Caller.
Yes. Well, typically, the reason that they call them blocks is they will include Marcaine, which is a long-acting anesthetic, along with Kenalog.
Mm-hmm.
So they can have a dual component there, but is not classically a block that is just blocking a nerve, and that's typically a local injection.
So it's like the dentist.
That's correct.
Except it's longer term,
Yes.
Yeah, the other thing, as an internist type person, when I give somebody oral steroids, I'm concerned if they go longer than 4 to 6 weeks that they may suppress their adrenal gland. We did have one of our Twitter told me about their son who had these injections, and one day he twisted his ankle and arrived at the emergency room with no blood pressure. And that's what happens when you suppress your adrenal gland. Nobody is following up on these injections. If you do an injection with steroids in it, you're liable to suppress the adrenal gland after just 1 injection.
Wow. Do they have any
and the way you can tell is to do some blood tests, which they're not doing. You can monitor the status of your adrenal gland.
Are there any like long-term tests of this stuff at all?
Yes,
Okay.
you definitely can measure how well your adrenal gland functions. They give you an injection of the hormone in your brain that tells the adrenal gland to get going. It's called ACTH. And then you can measure whether or not the adrenal gland gets going by how much cortisol it cranks out, which is the body's steroid. And it's pretty easy to do. And you can also do 8 a.m. cortisol levels. But this is really mandatory in anybody who's had a steroid injection. And I think it should be after one steroid injection, to be quite frank, because these are called depot injections, depot, D-E-P-O, which means this stuff is mixed with oils and stuff to make it last longer. Well, how long is it lasting? Is it hitting the 6-week mark? And then we hear of people that go in, every 2 or 3 months for these injections. And Janelle, your comment is exactly correct. Steroids cause softening of important tissues, mainly ligaments and tendons. Those are the things that kind of hold your body together. So if you're loosening up ligaments in your back or your shoulder, you're likely to have more difficulty. And although we have no idea, about this little poll we did, all the 300 people did respond, that people reported they needed more medications after their injections.
Yeah.
Not quite sure what's going on. Admittedly, it was just a little screening poll, but, the obvious is not always an illusion.
Right.
And a lot of times science starts with these little observations, well, maybe it's true, maybe it's not, but let's look into it and find out. So,
Stephen, did you have any other questions?
Well, just to add that long-term steroids have been well known to cause cataracts.
Okay.
As well.
Interesting.
So you'd have trouble seeing to get to the clinic.
Right.
Exactly. Well, thank you.
Well, I certainly appreciate your expertise.
Thank you,
Taking my
Stephen.
call.
Thank you.
Thank you very much.
All right. Caller from area code 269. What's your name and what's your question?
Jesse Ray. I'm gonna question a couple of questions
Sure.
for you, Dr. Kline. One of them being, what's your thoughts on sympathetic nerve blocks? Because I underwent those for about 3 years and really didn't see much of a result, and it just kept getting pain in my lower back. And the other one is, why do doctors try to ramp run the idea of spinal cord stimulators down you, and what's your thoughts on those? Because I've heard mixed results about them.
Well, the spinal cord stimulators, according to our Twitter poll, work about 14% of the time. So that's our little poll, which 14% is 14%. You have to kind of decide yourself whether or not the cost and discomfort are worth it. Sympathetic nerve blocks, that's a very interesting idea. I actually did part of my PhD dissertation on the sympathetic nervous system, and it was supposedly going to be used in children with cerebral palsy, and theoretically it sounded like a great idea. It failed. And then the next thing that was tried on is reflex sympathetic dystrophy, which is closely aligned to complex regional pain syndrome, in which case the sympathetic nervous system seems to be misbehaving. It seems to sense little tiny points of pain as gigantic pain, and then all of a sudden it just starts reacting, like you've fallen out of a tree. So they did sympathetic nervous blocks in people with reflex sympathetic dystrophy. Also failed. So my current thinking is that sympathetic blocks are probably not a good idea. for anyone unless some new research comes along to show that they work and who they work for. Mm-hmm. So,
thank you, Jesse, for calling in. We have another caller from area code 215. What's your name and what's your question?
Hello?
Hi.
Can you hear me?
Yep, we could hear you. What's your
Hi,
name?
how are you, Janelle?
Hi.
It's Dr. Bill Mangina. Hi, Dr. Kline. How are you?
Hi, how are you?
I'm good. Is your caller still on the line, by the way?
No.
I'm sure he's still listening, but I just wondered. Okay, I just wanted to take about 2 minutes or maybe 3 to just put a little perspective on this. I think that Dr. Kline is basically correct, about some of the questionable things that people are doing, but I don't really want to focus on what he said. I want to focus on your caller. The science, for lack of a better term, behind doing epidural steroid injections has been well worked out over many, many years. I mean, as an anesthesiologist, first of all, it's not really true that anesthesiologists aren't pain management doctors solely because they do injections. The science and the study of pain by most anesthesiologists goes way, way much more sophisticated than I think we're letting on here. But I understand the issue here, and the issue is something that I've talked about frequently in all my blogs in the past. That is that the interventional pain specialists are getting away with a degree of freedom in the repetitive amount of nerve blocks that they're doing on a whole lot of patients, which probably in general don't work as well as they advertise it to work. And in addition, I think what's been left out of this conversation, I'm sure Dr. Kline will agree, there's a tremendous medical economic complex consisting of companies which make all different kinds of epidural catheters, all kinds of equipment, including ultrasound-guided nerve blocks, and there's a tremendous, background behind the scenes of industry behind interventional pain medicine, and also behind spinal fusions, which aren't exactly the cat's meow of all treatments either, because most of the patients that wind up having spinal fusions are poorly selected for the procedure. That is, in those particular patients, the operation, even if it's done perfectly, was never really designed to relieve pain in those patients. It does relieve pain in a lot of patients. So before we get into all this, I just want to put a little perspective on this. I'm going to blog on it, and I'm going to talk about it down the line. But for now, the caller has a legitimate gripe. Too many nerve blocks. I grew up medically in a training program where probably the leading interventional doctors in the world were at the University of Illinois, Dr. Alon Winnie. Anybody who knows about pain. And I was also friendly with Dr. John Bonica, who started that pain clinic Dr. Kline described at the University of Washington, Seattle. And that was based on a biopsychosocial physical approach to treating pain. And it's a good approach, and it will work. But the problem is that that's a whole nother focus. But I just wanted to touch bases that we need to be careful, because I also agree that interventional procedures are overused. And I also agree that prosecutors will go after a doctor who uses opioids. And one of the reasons is that the interventional clinics are not going to give you opioids once you're out of insurance. They're not going to take care of the nuts and bolts of your pain, which is holding your hand, being compassionate, giving you the appropriate amount of pain medication you need to relieve about half your pain. So it's scandalous. There's no doubt about it. And I blog on it, and maybe you all should start reading some of the things I say, because I address every one of these issues that's being talked about tonight, and will continue to do so. One more thing. FDA approval for epidural steroids, the medications are approved, and there's no FDA approval for sticking a needle in somebody's back. So I don't agree with a caller about that. It's not that all epidurals are bad for you, and that one epidural can cause complications. The real issue is that it's the repeat use of the drugs when the doctors know damn well they're probably not going to work. That's the scandal involved. So I got that off my chest, and I'm going to say goodbye for the night. Thanks.
Thank you, Dr. Mangina.
I don't have anything else to say. All right, bye-bye.
Bye-bye. Thank you.
Yeah, spinal fusion surgery. We did do a little Twitter poll on that. We only had 100 voting, but that means 100 people had the back surgery. 75% said it was not worth doing.
The spinal fusions?
Yeah,
okay.
Yeah, this back surgery and fusion. 23% it worked. There's a much larger issue here. We're talking about surgeries and spinal implants and blah, blah, blah. There's a much easier and safer way to take care of chronic pain, and it is 50 centuries use of opioid and opiate pain medicines. In other words, if you're looking to get a spinal injection, it's only temporary. None of this stuff is curative. It's not curative to have the injections. It's not curative to go to a physical therapist. 75% of the time, it's not curative to have back surgery. So if the condition is not getting worse, why are we not just giving pain medicines? They're safer, cheaper, and a lot more effective.
Well, it's vilified, though, right?
It's vilified, but I'm sorry, we run a medical science. I mean, if we're going to go running around and saying, oh, we're doing what the government tells us to do, we've got a long couple thousand years of practicing medicine, and along the way, there have always been people telling us what to do. And if you don't stand up, guess what? You're going to do the wrong thing. And what we're seeing with all these pain clinics is doing the wrong thing.
Right.
Basically, it should be you go to a pain clinic, and as the caller mentioned, there are a lot of anesthesiologists who are well trained in giving the pain medicines. Why aren't they doing it? In other words, if you go to a pain clinic and you fail on full dose pain medicine, which is still legal in the United States, it's still legal for me to prescribe any FDA-approved opiate pain medicine to any point that I find that it takes to work. In other words, it doesn't matter how many milligrams are on the box. It matters whether or not I'm getting pain control. It's actually similar to Coumadin. When we check Coumadin blood levels, we don't care how many milligrams it's taken to get the blood level. We don't run around going, oh no, 4 milligrams, that's way too much. It doesn't matter. And it doesn't matter in pain either. So I think an intelligent, simple approach, if you just dropped in from Mars, would be, oh, you've got this safe medicine that you can take that has virtually no long-term side effects. We've had 5,000 years experience with it. Why don't you just take that at a proper dose? And if it doesn't work, come back and we'll consider doing some surgery, or we'll consider doing some physical therapy. We'll consider doing an implant or an injection. It's backwards.
Yeah, it really is. We have another caller from area code 570. What's your name?
Charlene Bedford.
Hi, Charlene. What's your question?
Hi. I'm talked to Dr. Kline before. I'm the person who actually works. I'm a CMS government contractor. I just wanted to ask you, Dr. Kline, do you think that now your followers are growing, that we can do some new polls maybe?
Yeah,
to take with us to the FDA. And another thing I wanted to say before you ended this, if you're going to air this, I believe you will. The FDA is having an open comment period from now, I believe, until May 30th. They're taking electronic comments. They say they want to listen to patients. We'll see what happens. And then there's going to be, like, I guess, an open hearing or something in September, which I plan on going to. So I was thinking if we could get some new polls before then, to take with us, it would be beneficial.
Yep, email me with any ideas. And, we've got so many followers now that I think the polls, are pretty accurate. They're not super accurate. On the other hand, nobody else is doing polls. So, CDC was supposed to have done follow-up of all the potential problems, and they haven't done it. So, either I can do the polls, or it'd be nice if CDC did the polls. And yes, we need new information for the I thought it was July, though.
It's July 6th or 7th, I believe.
Yeah. You know what? I think there's going to be a lot of people there.
I know. Me too.
I think so.
Yeah.
Yeah, but
so.
no, new polls.
We need
Anybody
to
that has any idea for polls, just email me at Thomas Kline, Kline, MD, at gmail.com.
Charlene, did you have any other questions?
No, I just wanted to make 2 more comments. They're forcing me in injections too, and my meds have been cut. Same thing, I can't prescribe due to the CDC. So now I had 3 SI joint epidural injections, which did not work and crushed me so bad I couldn't walk for a week. So now I have half the meds I used to. Now they're forcing me to get my nerves burned, which is, I guess, a 2-step diagnostic procedure. And then the next one, they're going to actually do the surgery. The first one I got like 2 weeks ago, I couldn't walk for 5 days. I was in so much pain. I was, for the first time, I prayed to God to die in my life. And I have 2 small children. And then I felt bad and cried and prayed to God to take back what I said, because I love my children and I can't leave them. Like, this is just, it's beyond, I don't even know how to describe it. There's no words, And I have half the meds I used to, and now they're forcing me to do it. And my doctor flat out told me if I didn't agree with her, I can go find someone else.
Yeah.
I called every doctor from here to New York City. I'm in Pennsylvania. Everyone, it was like almost like it was a speech. We no longer prescribe opiate medications, but we do injections. You're welcome to set up an appointment. Right off the bat.
Yeah, the best comeback is to say, you know what? If you treat me with full dose opiates and it doesn't work, then we can talk about your injections. Until you do that, I'm not going to participate. If they threaten to throw you out of the clinic, then you turn them into the Board of Registration of Medicine, because that is unethical.
I've heard that from countless people, though. Like, if you won't get like the SCS systems or the blocks or whatever, they'll turn you away.
It's starting to sound like this is sweeping the country, and it sounds like it needs investigation.
Yes.
By state boards are really the ones to do it. Mm-hmm. Practice of medicine really is a state issue. It's not a federal issue. There's actually laws preventing the federal government from interfering with the practice of medicine. I'm licensed in North Carolina. The Board of Registration watches out for my practice, not the federal government. So people need to file complaints. You can do it online with the just look up Board of Registration in your state. They all have different names. And there's always a little online button where you can file a complaint. Write it out ahead of time. Do not use emotional language. Just give the facts. I went to this particular clinic. I saw this particular doctor. They cut my pain medicines back and then told me I needed to have these painful injections.
Yeah.
That's unethical.
Absolutely. We have another caller from area code 267. What's your name?
Yes, my name's Rita.
Hi, Rita. What's your question?
I called in like last week, I believe, as well, and I didn't. I asked the question, but I kind of answered the question and answered it as well. So the question now for Dr. Kline is dealing with sickle cell disease, and patients with sickle cell disease now being told from primary care doctors and even some hematologists that they need to go and deal with pain management. And it's not been successful for my children. I don't know about from other patients, but it's not been successful for my children. Pain management says they don't know what to do. And then my child is in limbo with needing pain medication at home, not in the hospital, but at home, and not being able to get it, like getting a prescription for like 10 days. And then you still have to go back to pain management, like torturing them.
Yeah, pain management is a new word for, pain clinic, which is a new word for anesthesiologists doing injections and some giving pain medicines. Actually, the people that are primary care doctors, internists, pediatricians. They can prescribe pain medicine, and we've done so for decades. We don't refer every patient to consultants. If a child comes to me with an earache, I don't send them to a ear, nose, and throat surgeon. I send them to an ear, nose, and throat surgeon when I'm starting to have problems and I have concerns. Same thing with pain management or pain treatment. It's pain treatment. You're treating the pain just like you would treat lung disease, with treatments. And if I have a problem with a person with chronic lung disease and it's not working, I send them for a consultation with a pulmonologist. So if I'm having trouble with pain, I send them for a consultation. There's no reason that primary care physicians should not be prescribing pain medicines. And for kids with sickle cell anemia, there should be pain medicines at home, ready to go. There's no reason for kids with sickle cell anemia to have to suffer on the way to the emergency room and then be dissed, by the emergency room staff as a bunch of junkies. This is an issue that you need to bring up with your legislators. And when the legislators say, well, what do you want us to do? And your answer is, I want you to return pain care to the primary care doctors, and I want you to see to it that they are protected against unwarranted raids, unwarranted border registration activities. And they're going to say, well, how do we do that? Well, there are protection laws in California and in Alabama, I believe, or Louisiana rather, that are laws that protect people from not being treated for their pain and protects the doctors. The doctors need to band together with their state and county medical societies, and they need to retain lawyers to help them out if they are attacked unfairly. That's true for everybody. The DEA officers and all federal police officers belong to associations, and their associations help them buy insurance against being sued. A DEA agent cannot just charge into your home and violate your rights. FBI cannot do that. Nobody can do that. And if that's done, there's a procedure called the Bivens, B-I-V-E-N-S, where people can sue the agents individually. So why aren't doctors getting this protection? It's like in the 5th grade, I had to go duck and cover thinking there would be an atomic attack and put my hands over my head under my desk. That was an era of fear as well. But you have to kind of face what's going on and then do something about it, not just whine and take people off their pain medicines. The latest survey is showing that 70% of doctors have been frightened out of prescribing pain medicine. Mm-hmm. It is the family doctor's job to do that, and you wouldn't be having your problems being trundled off to, quote, pain management clinics who don't do anything over the phone, according to the one I just read, that if you're not there for an appointment, a scheduled appointment, they're not going to help you out. It's pretty bad, really. The pain contract that I read is just awful. I mean, and then people can't just say, no, they're not going to do it because guess what? No other place.
Right.
They gotcha.
So do they have to legally, do we need to sign pain contracts, or are they just doing that to protect themselves, the facilities? What's going on with that?
It's just to protect themselves. These are old tricks that they used in heroin addiction clinics, and most of the heroin addicted people agreed with it. In other words, it was helping them control their difficult drug addiction. These are not appropriate for pain clinics. They just humiliate people. You make a mistake and you're dropped off. Mm-hmm. We do have one person, Mercedes McGuire, who we know about, who had a pain contract, and she was being undertreated for her very serious pelvic disease. and went to an emergency room and said, look, I can't stand it. They're not giving me enough medicine. Please, for God's sake, do something. So they gave her a little teeny-weeny 3-day prescription. So she rushed over to the pharmacy because she was totally out at home. And the pharmacy said, gee, you have a pain contract here. And in the pain contract I just read here in Alamance County, it said you cannot get any pain medicine from any other doctor.
Mm-hmm.
So the pharmacist said, I'm sorry, you signed this contract. The emergency room doctor is another doctor.
Right.
And she said, but the pain contract says I can't call him up on an emergency basis. I can't call him on weekends. And the pharmacist said, I'm sorry, you signed this contract. So Mercedes went home and she killed herself.
Oh, my goodness.
Because there was no way out.
Wow.
And she had a 4-year-old son. That's what a pain contract did to her life.
Yeah.
And what under treatment did to her life. This trying to reduce everybody's medicines, there's nothing in the CDC regulations that says you have to reduce medicines. There's nothing in there that says that 90 milligrams is a cutoff for long-term treatment, only for the first prescriptions.
What about urine analysis? I mean, do they have to do those, or is that just another thing?
No, that's just another thing. They are making money on it because they buy these little kits,
mm-hmm.
and they do their own urinalysis, which are horribly inaccurate, and then they just kick people out of the clinic, if they're not turning up with the right lab test. It's just awful. I don't know how else to say it. To humiliate people like that, and then if you really need your pain medicines, you can't get any more pain medicine, and then you go on the computers as a drug seeker.
Right.
And do you know what happens? It turns up on every single computer in the United States.
Right.
With software developed by the Brandeis University School, Heller School. They have developed this so that if you go to Anchorage, Alaska, it'll pop up. You're a drug seeker. Guess what? We're not going to give you any pain medicine. So for the rest of your life, forever, you will get no pain medicine after surgery, in the emergency room, or for a chronic pain condition. That's what the Brandeis prescription drug monitoring program has done for people, violated their rights, pain clinics dropping people right and left because of some phony urinalysis onto the computer, onto the Brandeis computer, drug seeker, criminal, addicted person.
Yeah.
So.
We have a question. A doctor can deny you for any reason he deems factually for being at a pain management clinic. Why pain contracts then if they can deny you?
Yeah, good point. I think they're just covering their tushes so that if the DEA raids, the DEA's been closing these pain clinics down. I don't know why. I'm not going to say they were crooks because I know a lot of doctors that have been attacked by the DEA, and I can tell you that they're probably not crooks. So there's a lot of hysteria. We're in an era of opioid hysteria, just like the hysteria of the McCarthy hearings, just like the hysteria of the crack cocaine, just like the hysteria of the witches in Salem. Bad things happen during hysteria. People become so frightened they'll do anything. And that's what's happening right now. There's 5 to 6 million people in the United States that are being cut off their medicines. And latest figure is that 80% of them are going to pain clinics. So as the doctor said, this is becoming quite the cottage industry.
Right. We have another question. If we're branded as drug seekers, is there any way to find out ourselves?
You have legal rights under HIPAA. You have to look it up under the HIPAA privacy laws to get hold of your records and make corrections. You can call in a lawyer. This is when a call from a lawyer helps out. Say, we need the records for this patient. She's entitled to them, and we'd like to have them fairly soon and at low cost. You are entitled to your own medical records. And if they give you a hard time, back to the filing a complaint with the Board of Registration in Medicine.
Yeah, because I've heard a lot of people ask for their records and they won't give them to them. Another question we had is, what should a patient do if there's false information within their records?
Yeah, that's the HIPAA. You have to look up the HIPAA law and just Google how to fix wrong medical records and see if you get into the HIPAA privacy laws. There's definitely a law that allows you to make corrections in your medical record. I think if there's false information in your medical record, it's worth paying a lawyer a couple of hours to help you out. I mean, for a few $100s, I mean, you get in an electronic medical record, and I can guarantee it's going to show up in every emergency room in this country.
Well, you have to remember, though, a lot of people are on disability. We only get maybe a few $100s, a month. I mean, you're lucky if you get over that. So it's hard, but you're absolutely right. Something else I wanted to ask you about is titration, because I don't think people realize what that actually is and how it's properly done. Can you explain that?
Titration is, I don't know if you've ever mixed up pancake batter or mixed up cement or mortar. Those are all examples of titration. And what it is you've got a big bowl of your pancake powder, and you start adding water to it, and you start stirring it, and you add quite a bit of water. Same with cement. You add a lot of water. All of a sudden, you get very close to the point that it's going to be correct, and it only takes a teeny little bit of water to make your pancake batter perfect, or to make your mortar mix perfect before you cement your wall. So those are both examples of titration. What it means is you move up on the mixture. So in other words, you move up on the pain medicine. And the old rule of thumb that I was taught back in medical school, that was before there were cars, but anyway, is somebody's in pain, you give them 10 milligrams. It doesn't work, you give them 20. If it doesn't work, you give them 40. You just keep going until it works. You jump on the pain, because if you don't, like making pain medicine's second choice, which was not CDC's responsibility to say, because they are not an agency that's provided by law to be the regulatory agency. They had no business saying that because that's harmful. You jump on it with pain medicine, or else you start getting these chronic pain syndromes. Anyway, then when you're at a certain level of your pain medicine, you kind of wait a couple days, and then you add a little more, because sometimes that addition of 5 milligrams or 10 milligrams will make your batter perfect. And now you've got 100% pain control with a tiny little bit of medicine, whereas before maybe you only had 85%. So that's the trick with titration, and that's what's approved in all the medical books that you read, in all the textbooks on pharmacology, and that's what's in the FDA regulations. Anybody who's not doing that needs to explain themselves.
Do doctors at pain management clinics make money off of different treatments or medications?
Well, if you're a physician and you are doing a procedure of any kind, surgery or reading an x-ray or doing an injection, there are two components that are billed. One is the component for the procedure itself in the clinic. That's catheters and medicines and things. And the other is the physician component. So I don't know what they are. You may have a $10,000 bill from the operating room, and maybe $3,000 or $2,000 goes to the surgeon. You may have a $1,500 injection procedure, which a lot of the money goes for the materials, and I don't know how much the doctors get. That would be an interesting thing to look up. But I would imagine it's at least a third. That's sort of the kind of the old rule of thumb.
Is there somewhere where we can find that information out? I mean, is that public knowledge?
Yeah, no, it's public information. There are, Medicare keeps fee scales, and you can go to Medicare and find out, say, what is the code and the payment for anything, an office call, a spinal injection. Of course, it gets complicated because they got codes for different kinds of injections and blah, blah, blah.
Right.
But you can try Googling it, too. I would imagine Google can turn up anything, since the other day I just found out by Googling that the Earth is not flat.
Oh, you're not a flat earther?
No, I gave it up.
That's fun. Another question I get a lot is, how come the cost of a urine analysis is different from pain clinic to pain clinic? Like, how do they figure that out? Like, in what to charge patients?
They make it up.
They do. Okay.
Yep.
Wow. Other than prescribing medications, what other treatments do they generally do? I mean, do they do physical therapy at pain management clinics?
Physical therapy is pretty common. They try Tai Chi. They try all these things that we all know as doctors don't work, or else we would have done this a long time ago.
Right.
Sending somebody with severe back pain to a physical therapist might be good for one visit, and kind of actually I like to get the therapist's views. Therapists are good diagnosticians too. And back problems are so complicated. It's kind of like getting another doctor's opinion, because they're, like doctors. I mean, they're very skilled with this. But that's not very often. Most of chronic back problems are simply chronic back problems or failed surgical syndromes, where people have had surgery and now they have this god-awful pain. And so, I look at it kind of the other way. I said, start them on some pain medicine, for heaven's sake, relieve their pain, like we've been doing for 5,000 years. And then, and now that their pain is a little better, then you can send them to the physical therapist and find out if that's going to help a little bit more, not the other way around.
Well, isn't that what partly pain medication is for? So it can alleviate the pain enough so you could get moving again and working whatever issue there was?
Absolutely. And, trying to mobilize a painful back in the therapist's office usually leads to disaster. I mean, I've had so many people telling me they just screamed and ran out in agony. No, that's the wrong way to do it. You control the pain with this wonderful, safe medication that Mother Nature gave us, like I say, in use since ancient Mesopotamia. If this stuff didn't work, it would have stopped a long time ago, and it works great. Mm-hmm. In spite of the fibs, I'm afraid to say, in the CDC regulations or CDC suggestions, because they made a conscious decision. The researchers, Roger Chow in the University of Oregon, who was one of the writers, did a study, and they purposely excluded all pain studies under 3 months.
Wow. They
just did away with them. And then they said, whoa, we don't have any long-term studies. Therefore, this stuff must not work. This is not scientific integrity. Mm. All the pain medicine trials are short because they would be unethical to do them long-term. So you give pain medicine to a bunch of people, relieve their pain, and you got a whole bunch of people over here. You say, no, you don't need pain medicine. You're going to be the placebo group for the next 12 months.
Well, who said it was unethical?
Well, it is just inherently unethical.
Okay.
It would be like if when you treat a strep throat, you're actually preventing rheumatic fever.
Okay.
That's the reason to treat a strep throat. Otherwise, it would just go away on its own. But you're trying to prevent a much more serious disease and cause heart problems and everything. So if you weren't sure that penicillin worked, because there's no study to show that it did, because we all know that it works, then you would take a group of people and you would say, okay, when you have your sore throat, you gargle. And then you've got the group over here you're giving penicillin to. Well, it's unethical if you know pretty much for sure that the people without the penicillin are going to end up with rheumatic fever. Same thing with pain medicines. We know they work. They've worked for hundreds of years in the U.S. and thousands of years. We know they work. Mm-hmm. So then it becomes unethical to do a study with a medicine you know is going to be helpful, especially long-term study. All the short-term studies, which are appropriate, have shown that the pain medicines work fine, and the addiction rate is very low. The most famous one was Nobel's, NOBLE, LE, Nobel's study in 2010, and it was fine. These drugs work, and they only had a 1% addiction rate. But those studies were cast aside in the big ARQ 2000 or 213 or 218 study. That's the mainstay of the CDC regulations and the Canadian regulations. Wow. This is the study they all rely on to say, we don't know if pain medicines work. What an absurd thing to do. What a dishonest scientific thing to do.
Right. Wow. We have several people asking about radio frequency. Can you
radio
explain?
Frequency ablation? I honestly don't know a lot about that.
Okay.
And until I knew more, I wouldn't do it. So we can look into that. We'll do a Twitter poll and see if it works. Yeah. I've had a couple of patients, that's anecdotal, that just suffered greatly during these things. So I'll try to look into that. Maybe we can do a little poll.
Also, several people have told me they've been turned away because of the extent of their health issues. Why would a pain clinic turn somebody away because of how many issues they have? I mean, where are they supposed to go then?
Yeah, well, I guess they can go to Mexico or Cuba.
Right. Well,
but that's just horrible. I mean, that's not the practice of medicine. What is that?
I don't know.
That's not healing.
No, it's not.
That's I don't know what to call it other than horrible.
Yeah, definitely. Well, it is already that time. Did you want to have any last words?
Basically, my review of pain clinics, and that is from the folks on the Twitter feed, the 19,000 people, and the little polls that we've done, is I have serious reservations about pain management clinics. And the worst and the most serious reservation I have is that it seems like an awful lot of them are not using the basic tool of pain relief, which is opiate pain medicine.
Okay.
So,
well, thanks, Dr. Kline, for joining us this evening.
You're welcome.
And tomorrow evening, Dr. William Mangino will be our guest. He's an anesthesiologist, pain management doctor, and advocate. Thank you, Call Nation, for joining us on another Tuesday evening at the Doctor's Corner. I'm Janelle Elgaway, signing off until tomorrow evening. Good night.
You've been listening to The Doctor's Corner with Dr. Kline and Janelle Elgaway. Copyright 2018 by EXG LLC. All rights reserved.